EMT. I'm also a certified American Red Cross instructor certified for this course. Go around the room and say your name and why you're getting certified or recertified today.
My name is Cody. I'm getting certified because I'm starting a job.
What do you do?
As a psychiatric technician.
Okay. When we do this here, I know where you work. I can gear them a little bit more towards what you might actually encounter.
My name is Hilda Jimenez, and I'm getting certified because I'm get a job as a CCNA.
Hi, my name is Pascal Hayek, and I'm a pharmacist. I needed to name my.
I'm Sarah, and I'm getting recertified so that I can finalize my athletic training certification.
Okay, cool. Great. Okay. Basic life support for adults. What we're going to do, okay. We came up with a new, you refer to this, it's in your book that you have electronically. You'll have access to that for up to 18 months. And it kind of expires about 6 months before you recertify. You have to recertify. Going through how you handle different situations, code card. Okay. Rapid assessment. When you perform a rapid assessment, that's the very first steps of recognizing and assessing, recognizing, and caring for the patient. When you walk up, you want to figure out what's going on. Okay. Then perform the rapid assessment in these following steps. Conduct a quick visual survey. See what's going on. Okay. Look what's going on. This is also where you make sure the scene is safe for you. If there's a down telephone pole with electrical wires and everything else, you don't necessarily want to go in there. Okay. Figure out what's going on. Obtain initial impression of the patient. What's wrong with them? What happened to them? Okay. Look for any life-threatening bleeding. If you go, oh my God, it's a lot of blood, it probably is. You need to make it stop. That's a life-threatening bleeding. Okay. And determine need for additional resources. Who do I need to call for help? Okay. That's your rapid assessment. Next, you obtain consent. If they're responsive, can I help you? Hey, I'm Chris, I'm an EMT. Can I help you? What's wrong with you? Okay. If they have an altered mental status, or they're in shock or something like that, they can't verbally give consent, you have implied consent. If the patient appears unresponsive during the initial impression, we're going to check for responsiveness. How do we check for responsiveness on an unresponsive patient?
Tap the shoulder, shout, and tap.
Yeah, shout, tap, shout, right? Hey, are you okay? And tap the shoulders. Hey, are you okay? Okay. Then call for help. Okay. Or have someone go get help. Once you've done that, you will then open the airway, doing the head tilt chin. You're going to open the airway and listen for breathing. You're also going to check for a pulse at the same time. If you suspect a head, neck, or spinal injury, you'll use the modified jaw thrust. Okay. Check for a pulse for no more than 10 seconds. At the same time, you're standing by for any more life-threatening bleeding and checking breathing. If at any time the patient has life-threatening bleeding, control the hemorrhaging with any available resources, okay, including a tourniquet or a hemostatic dressing. Okay. Activate EMS. You've not already done so. Use the ABC memory to easily recall and perform the assessment. Airway. Check for the presence of or absence of breathing. Okay. Breathing, assessing for circulation. By a pulse check. Where do we check for a pulse on an adult? Carotid artery. Okay. So you have the medic will be there. You'll come up. You're going to visually look at the area, see what's going on. Okay. They're unresponsive. Hey, are you okay? Hey, are you okay? And you lean down. Do the head tilt chin. Listen for breathing and check for the pulse at the same time. Okay? All right, everyone go ahead and we'll do a practice scenario where you check, do the initial assessment, and check for pulse and breathing simultaneously for no more than 10 seconds. So let's say you were leaving class today, You walked out front and you find someone that's collapsed on the sidewalk from the building to the parking area. Go. Everyone can do it. You're standing on his legs.
On the
You're gonna
side.
be on his side, right?
Yes.
Remember, they have arms and legs, just like we do. Alright, you check for responsiveness, then what are you gonna do? Check for pulse and circulation, right? Or pulse and breathing. Go ahead and check for pulse and breathing. One other thing, when you're checking for pulse and breathing, when you check the pulse on his, you're checking on the same side you were on. Do not reach across the throat to check for pulse. So if someone's walking by, what does it look like you are doing? It looks like you are choking them. Also, you can impede the airway by doing that. So you always, when you do the head tilt chin, take your fingers and come back, and you're checking on the same side you are on. Okay? Okay? Now you can sit back in the chairs. Injuries or illnesses. When you're doing your assessment, you're going to find things. You got to figure out what it is. Is it an illness? Is it an injury? Life-threatening? Non-life-threatening? Alright. Miss Sparks is unresponsive, breathing normally, and has a pulse. You do not suspect a head, neck, or spinal or pelvic injury. How should you respond?
Call 911.
You can call 911. Yeah, you want to check, make sure nothing else is wrong. You can call 911. What else? What position are you going to place her in? Okay. Activate EMS, perform a primary assessment. Okay. Position Miss Sparks as appropriate for clinical condition. If she is lying down and does not have a suspected head, neck, or spinal injury, you should place her in the recovery position and then perform a secondary assessment. Okay. For a suspected or known opioid overdose, administer naloxone following the manufacturer's instructions or the facility's policy for naloxone administration. Subsequent doses of naloxone may be repeated every 2 to 3 minutes as needed. Do not, this is key, don't delay treating them if they have a condition that needs to be treated to wait for the naloxone if you suspect an opioid overdose. Okay? So like in this case, if she wasn't breathing, you would do, she'd be in respiratory arrest, you would do respirations until you got the naloxone. Okay. Respiratory arrest or failure in adults. The next presented with assessment findings for an adult patient in respiratory arrest or failure and be asked to determine the appropriate care. Mr. Martell is an adult patient in respiratory arrest. How should you respond?
Ventilation.
What?
Give them ventilation.
How many and how often?
1 every 6 seconds.
1 every 6 seconds, yeah. Activate, whenever you have someone that's unresponsive, you're going to activate EMS first. Okay, then deliver 1 ventilation every 6 seconds. Okay, again, perform the primary. Continue to check breathing and pulse every 2 minutes. Okay, the patient pulse becomes active, then start CPR. When you're giving ventilation, you need to reassess every 2 minutes. How many rescue breaths would you give in 2 minutes to an adult? 1 every 6 seconds. 20, yeah. If you don't look at your watch, and you know you're counting your breaths, you've done 20 breaths, it's time to reassess the patient, okay? Again, if you suspect an opioid overdose, make them breathe or give ventilation. When naloxone becomes available, go ahead and administer it. Okay. Cardiac arrest in adults. Here's a breakdown of how you would respond. Okay, in addition to basic life support, adults and adolescents code card, you may refer to the following code cards throughout this topic: suspected or known opioid overdose, and basic life support for pregnant patients, which we'll touch briefly on. Components of high quality CPR. You're presented with assessment findings in an adult patient in cardiac arrest and be asked to determine the appropriate care. Miss Rigby is in cardiac arrest. What are the components of high quality CPR when caring for this patient? What do you do? She's in cardiac arrest.
Start CPR.
Start CPR, yeah. What are the components of high quality CPR?
30 compressions to
30 compressions to 2 rescue breaths, yep. How far do we compress the chest?
2 inches deep.
At least 2 inches, yeah. Okay, assess for breathing and pulse for no more than 10 seconds. Once you determine it's cardiac arrest, immediately start CPR. Then use an AED when it's available. Hand position. Center of the lower half of the sternum, at least 2 inches. We want a rate of 100 to 120 per minute. We want 100 to 120 compressions per minute. Each cycle that you give of 32 should take anywhere between 15 and 18 seconds. Compression to ventilation ratio, 32. You want to avoid excess ventilation. You just need to ventilate to see the chest rise for no more than 1 second. The other big key is limit your interruptions when you stop compressions to give the ventilations to no more than 10 seconds. The other key here is if you have an advanced airway in place, one provider will deliver ventilations every 6 seconds, and the other provider will continue continuous compressions. You do not stop for the ventilations. It would be 100 to 120 compressions per minute, and you do not interrupt the compressions to ventilate. Okay. If you have a person suspected in a drowning situation and they are in cardiac arrest, you'll deliver 2 ventilations before you start CPR for a drowning patient. If you have a submersion incident and the person is in cardiac arrest, you will deliver 2 ventilations before you start CPR. If Ms. Rigby were in cardiac arrest due to an opioid overdose, what would you modify?
Have the naloxone.
Yeah, get the naloxone, and you start CPR, activate EMS, you do everything else, and then administer naloxone when it becomes available according to the manufacturer's instructions. Okay. The other key is checking for responsiveness or checking for pulse and breathing every 2 minutes. Okay. If Miss Rigby were 34 weeks pregnant, with a fundus above the umbilicus, how would you modify care?
Do the left uterus tilt.
Yep. Activate maternal and neonatal resuscitation teams, remove fetal monitor in a pre-hospital setting, transport ASAP to appropriate facility, provide high-quality CPR and continuous left uterine displacement, blood, provide continuous blood until the infant is delivered, even if ROS is achieved, and then have a C-section done. Okay. Does everyone understand what the LUD is? How you do it?
Not really.
Not really. So the way they tell you to do it is place the patient on the left side. You'll have 3 people. 2 people will be on the right hand side. Push something under some type of wedge underneath the right buttock so they're up. And then have 1 person hold up on the belly to relieve the pressure from the veins, and the 3rd person will be doing the compressions. Okay. Components of high quality CPR. You will learn to perform high quality CPR as a progression. You'll perform chest compressions. You'll deliver ventilation. You will use a pocket mask. Perform CPR cycles as a single provider CPR. You'll use a BVM, and then perform CPR cycles as part of a multiple provider CPR team. Chest compressions.
To provide provide high-quality chest compressions, you must use correct hand placement and body position, compress at a proper depth and rate, allow for full chest recoil, and minimize interruptions to less than 10 seconds. During chest compressions, proper technique is critical. So first, place the patient on a firm, flat surface. In a healthcare setting, use a bed with a CPR feature or place a CPR board under the patient. Adjust the bed to an appropriate working height or use a step stool. Lower the bed side rails closest to you. In other settings, move the patient to the floor or the ground and kneel beside them. Next, expose the patient's chest so you can ensure proper hand placement and visualize chest recoil. Now, position your hands correctly. Place the heel of one hand in the center of the patient's chest on the lower half of the sternum. Place your other hand on top of the first one and interlace your fingers or hold them up so they don't rest on the patient's chest. Then, position yourself so your shoulders are directly over your hands. This position lets you compress the chest using a straight up and down motion. This is more effective and less tiring. To help keep your arms straight, lock your elbows. For an adult, compress the chest at least 2 inches. If you're using a feedback device, make sure the compressions are no more than 2.4 inches deep. Provide smooth compressions at a rate between 100 to 120 per minute, like this. Allow the chest to fully recoil after each compression. Avoid leaning on the patient's chest at the top of the compression because doing so impedes venous return and prevents the heart from filling completely. This, in turn, decreases cardiac output. Here's what a cycle of compressions looks like. 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10 and 11 and 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
Any questions about chest compressions? When you're doing chest compressions, you mentioned in the video when you can stop. Okay. When can you stop giving CPR?
Someone relieve you.
Someone relieve you. They have to be BLS or higher to relieve you. Okay, they have to be BLS or higher to relieve you. Whether it be an EMS team or an advanced team in a facility, BLS or higher relieves you. What else?
When there's some movement.
Return to spontaneous circulation, right? We achieve ROS where they start moving. Immediately yell stop CPR and then check for pulse and breathing. When else can we stop giving CPR?
When it's dangerous to us.
Yeah, the scene becomes unsafe. Save yourself. Okay. What else?
When the EMS arrives.
Wait.
When the EMS arrives.
That's an advanced team.
Yeah.
Advanced team where BLS or higher relieves you.
Mm-hmm.
You're too exhausted to continue.
You are too exhausted to continue. And there's one more.
Isn't it when the AED is like,
Well, the AED will still tell you continue CPR because you're pausing, you're not actually stopping. I mean, you can stop doing everything.
yeah.
When's the last time you can stop doing anything for the patient?
So if you have the non-resuscitation,
What? You have what?
if you have the non-resuscitation form,
You have a DNR, a do not resuscitate order. Okay. In Virginia, a do not resuscitate order is an actual form signed by the doctor. It has to be signed by the doctor. Okay. If you have one of those, you can stop. Those are the only times you can stop giving CPR. Okay. These mannequins have a feedback mechanism. When you get down, if the white line is down, turn it off and then turn it back on, and then the chest will light up. Okay. When you're going to give your compressions, the base of your hand goes on the lower half of the sternum. As BLS provides, we expose the chest first. Okay. We get our hand on the lower half of the sternum. Basically, our middle finger is going to go across their nipple line. Interlace your fingers together. Lock your elbows. Get your shoulders square over. And then you are going to compress to at least 2 inches. Okay. Any questions about compressions?
With the heel of the palm.
What?
With the heel of the palm.
heel of your hand goes right on the sternum. Yep. All right. We're gonna do. You'll do your primary assessment. You'll check for responsiveness. You'll check the scene. Check for responsiveness. You'll check for breathing and a pulse simultaneously for no more than 10 seconds. Tell me to call for help, and then you'll start compressions. You will do compressions for 1 minute. During this time, I will help you. I'm going to play a metronome. My metronome is set to 110 compressions, so right in the middle of where you need to be. All right, you'll do compressions for 1 minute. All right, go.
Sir, are you okay? Are you okay?
Are you okay? Are you?
Just the compressions or the whole assessment?
The whole thing.
Okay. Hey, are you okay?
What do you do now?
Call 911.
I'll call 911, get you an AED. I'll call 911, get an AED.
Call 911.
Remember, when you check, you're checking on the same side you are on
Okay, okay.
simultaneously. At the same time, you're checking for breathing. Use your hand at the forehead, tilt the head back, your other hand goes down and check. And you're going to check for breathing at the same time. Use the hand at the, switch your hands.
Switch one. Okay.
Put that, and do the head tilt chin, then move your fingers down. You can start.
Call 911.
I'll call 911 and get an AED. Every one of those beeps is a compression. Quicker. You gotta go quicker. Every one of those beeps is a compression, okay? 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10, 11, 12, 13, 14. I don't remember. That's the pace. A little too quick. You're gonna need. Top is a minute of compressions. Stop. Alright. That was a minute of compressions. I'm not going to play the metronome and get it up to keep track of your own. So that's the first one. That's the pace that you need to be on, okay? That was 110 compressions. We're right in the middle. Alright? Any questions about compressions? Pocket mask use.
To use a pocket mask, first select an appropriately sized mask and then assemble it like this. Place the mask at the bridge of the nose, then lower it over the patient's nose and mouth, making sure it doesn't extend past the chin. To seal the mask, place the webbing between your index finger and thumb at the top of the mask above the valve. Then place your remaining fingers on the side of the patient's face. Now, place the thumb of your other hand along the base of the mask and place your bent index finger under the patient's chin. Open the airway to pass neutral, take a normal breath, make a complete seal over the mask valve with your mouth, and give 2 ventilations. Each ventilation should last about 1 second and make the chest begin to rise. Remember, between ventilations, quickly break the seal and take another breath.
Alright, you have brand new pocket masks. These are going to be yours to keep. You can go ahead and take them up, take them out. When you take them out of the case, they're going to be flat. You cannot use it this way. Don't try to use it this way. Pop it up, make it look like a tent. Alright? Place where the tube and the mask come together in your thumb and index finger. Pointing under the mask typically goes towards the nose. Place it on, tilt chin back. I'm squeezing down on the mask. Take your other hand, place the finger underneath the chin, your thumb on the mask. Then lean down. and you see just enough to see the chest rise. Break it, get a new seal. Okay. We're gonna go around the room one at a time. You're each gonna demonstrate this for me. Put the pocket mask away. Those are yours to keep. In real life, if you were to use one of these, you would either have to replace the tube, get a new tube, or get rid of the mask and get a new mask. Okay.
You can only use it once.
What?
You can only use it once.
Or use it one, yeah, because the tube is the tube has a filter in it, so it's filtering out all the bad stuff from them and you, so you don't want to go then use it on someone else. For the rest of today, we will be simulating breaths or using a BVM. Okay. It doesn't go in the bag. It goes in the case.
Yeah.
The case goes in the bag. All right, any questions about the pocket mask? All right. You did the ventilations. Single provider CPR.
For adults, each CPR cycle consists of 30 chest compressions followed by 2 ventilations. Remember to smoothly transition between compressions and ventilations to minimize the interruptions in compressions to less than 10 seconds. Here's what a cycle looks like with one provider. 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10 and 11 and 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. One and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10.
All right, here's your skill practice. You'll check the scene, make sure it's safe. You'll check for responsiveness. You'll check for pulse and breathing. Okay. You'll then perform 3 cycles of 30 to 2. Okay. For your breaths for this, we are going to simulate them. You will just pinch the nose, do the head tilt chin, pinch the nose. Say breath 1/1000. Breath, and then you'll resume your compressions. You'll do 3 cycles. Okay? Any questions? All right, go.
Sir, are you okay?
Sir, are you
Are
okay?
you okay?
Gosh, tell you to call 911.
Yep.
Call 911.
I'll call 911 and get an
Get
AED.
an AED.
Good job. 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10, 11, 12, 13, 14, 15. Your paces have to be quicker, ma'am.
I just let it be cold or?
It has to be quicker, yeah. Your compressions need to be deeper. Just 2 inches. Very good. Your compressions need to be deeper, 2 inches. You gotta go quicker. Yep. It's 1 and 2 and 3 and 4. It's 1 compression every 2 compressions, 1 every second. 2 compressions, 1 second. Alright. And the reason why we want to make sure we're doing this quick, and we want to make sure we're compressing the depth fully as well. If we don't compress the chest fully, we are not squeezing the heart enough to pump the blood out. What we are physically doing when we do CPR, we are taking the rib cage and we are compressing the rib cage down to squeeze the heart to pump the blood. When we allow the chest to fully recoil, it allows the chest to expand, the heart to re-expand, and fill with blood. That's why compression depth is important, and allowing the chest to fully recoil allows the heart to fully expand and have blood come in. Okay. BVM use, bag valve mask.
When you're the only provider present to operate the BVM, follow these steps. First, select an appropriately sized BVM. Then, if necessary, assemble the BVM. Next, position yourself behind the patient's head in a cephalic position. Place the mask at the bridge of the nose and lower it over the nose, mouth, and chin. The mask should not extend past the patient's chin. To hold the mask in place, position one hand around the mask, forming a C with the thumb and index finger, and an E with the last three fingers. This is the EC hand position. Then, seal the mask completely around the patient's mouth and nose by lifting the jaw into the mask. Be sure to maintain an open airway in the pass neutral position. Depress the bag about halfway to deliver a volume of 400 to 700 milliliters. Provide smooth, effortless ventilations that last about 1 second and begin to make the chest rise. Remember, ventilations that are too fast or have too much volume can be dangerous. Although a single provider often uses a BVM, evidence shows that 2 providers are needed to most effectively operate the equipment. I'll maintain an open airway and seal the mask using an EC hand position with both hands, like this.
And while Greg is doing that, I'll deliver ventilations by gently squeezing the bag about halfway to make the chest begin to rise, like this. Each ventilation should last about 1 second.
A 2-person technique for bag valve mask ventilations is the preferred methodology because it provides a better seal. With 2 people, 1 person there just holding the mask, they can get a better grip and hold it better than with just 1 person, especially if you have smaller hands. Okay. When only 1 provider delivers ventilations, providers may consider using a pocket mask. So if you are by yourself as a single provider, you're probably better off using a pocket mask than trying to use a BVM, because it would take too long in between compressions to give the breath. It would take longer than 10 seconds. Okay. If you do have 2 people, it is 1 person can now use the mask. If there was another provider doing compressions, I could do the bag by myself for them. The C forms around where the bag over the valve and the mask. Your other 3 fingers go on the bottom. That's what allows you to pull the chin back and hold it. Then you can push down and then squeeze the bag nice and gentle halfway, just to see the chest rise. Okay. The other nice thing about the bag valve mask is it provides a higher concentration of oxygen to the patient. Okay. What you do is you have a bag valve mask, you're always at the head of the patient. Okay. Try it by yourself. Deliver 3 sets of ventilations by yourself, and then get a partner, and then both of you can do it. So when you're both doing it, 1 person is going to hold the mask, and then the other person will squeeze the bag. Okay? All right. Remember, you are always at the head of the patient. You are always at the head of the patient in the valve. Yeah, turn your patient. He moves. He's easy to move today.
Yeah.
You gotta tilt the head back. Okay, the C goes around where the mask and the valve attach together. Remember, the pointy end of the mask goes towards the nose. The pointy end of the mask goes towards the nose. Good job. Let me see one of your breaths. Great job. Multiple provider CPR.
16, 17, 18,
Now let's watch as a team performs CPR already in progress.
25, 26, 27, 28, 29, 30. 1 and 2 and 3.
Switch positions about every 2 minutes, which should take no more than 10 seconds. The compressor calls for a position change by saying switch in place of the number 1 in the compression cycle, as Greg will show you.
25, 26, 27, 28, 29, 30. Switch and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10 and 11 and 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
One and 2 and 3 and 4 and 5 and 6.
As with any patient in cardiac arrest, if a patient shows obvious sign of life, stop CPR and monitor the airway, breathing, and pulse.
22, 23, 24, 25, 26, 27, 28, 29, 30. 1, 2, and 3, and 4, and 5, and 6, 8, and 9, and 10, 11, 12, 13, 14, 15, 16, 17, 18, 20, 21.
Stop CPR. I see movement.
I'll check for pulse and respiration. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000.
All right. We're going to divide into sets of 3. We're going to do it. We're going to rotate around. Okay. We perform 2 cycles of CPR. Okay. And you'll call for a switch and then provide 2 more cycles. The key when you call for a switch is you're not moving around the patient. Okay. So if I'm in this position and I'm doing compressions, I want to switch. I'd say switch 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. The other person would give the breath. They would then take over compressions. I would move the bag and then back. Okay, you're not switching positions. You're switching on and off from doing compressions. All right, does that make sense?
They do compressions on the other side. They start then doing compressions.
Person on this side will take compressions over from their side of the patient. Person maintaining the airway maintains the airway. Okay. Because if you try to move around the patient, that's going to take too much time. And this, the video shows an in-facility type situation. You're an athletic trainer. You're not going to be in a facility most likely. You're a pharmacist. Probably not going to be in a facility, right? You're going to be out somewhere, so you're not trying to get around the patient. You're just switching on and off is what you're doing when you switch. Okay. You'll start. Okay. You'll assess the scene. You'll check for responsiveness. Tell me to call for help. Check for pulse and breathing. Okay. And then call for help. They're going to go get help. They're going to come back. Okay. After he does his 2 cycles, he's going to call for a switch. You'll take over for him. You'll do 2 cycles and call for a switch. You'll take over. You'll do 2 cycles, call for a switch. Then you'll take over. You'll do 2 cycles and call for a switch. And you'll take over this new part of 1. Okay?
Where's the bag as well?
Yeah, the bag will be there. Okay. We need 3. You'll be bagger. You'll be the 3rd person. We'll rotate through.
Okay, so you'll show me to do this and it's all.
Yeah, you'll do the bag. Yeah, you're just hold it. Okay.
Ready?
Yep.
Okay. Sir, are you okay? Are you okay? Call 911 and get the AED.
Okay.
He's not breathing and there's no pulse.
We call for a switch that second time. We'll take over.
Do I get the AED?
We're not the AED yet. That's the full kill. That comes later.
It's broken.
Yeah. So your bag. Hold her bag. You can hold it. You're in a bag. You're in a bag.
person was from
She's holding out. You're right here. He's doing CPR. She's holding it. You're bagging. Squeeze, squeeze, breaths. One. Call for switch. So you'll get 2 more breaths, then you'll take over compressions. You'll come in. Make sure you're counting so your teammates can hear you when you know what to do. Call for a switch on this cycle. Okay, call for a switch on the next cycle.
You say switch one too.
Keep going.
Yeah.
Do one more, that's okay.
Switch.
Switch.
You are-
You give the breaths. You give the breaths. You need to say switch instead of one. To finish, do another cycle and say switch, 2, 3.
One. Switch.
Right, so when you say switch, you get to 30, that's when you switch out. Okay, now you're gonna get compressions. Call for a switch on the cycle. Now you're gonna step out. You're gonna hold the airway. Head back. Head back. Head back. You're looking over. Let him do that. Hold your breath.
Tilt the head back.
Call for a switch. Tilt the head back. There you go. Okay, you can stop now. You've done it. Okay. That's how team CPR works. You're just switching out. A great example of this happened last year that I know of, not in a controlled environment, in a very uncontrolled environment. There was a 72-year-old gentleman that had a cardiac condition while hiking by himself. He was found by a group of nurses from Dartmouth-Hitchcock, and they performed team CPR for about an hour and a half to get him off the mountain. Okay, so it does work, and that was a team environment, so they just kept switching out every 2 minutes. Okay.
I think it's the worst place where it could be because it'd be far out somewhere.
Yeah, they had to
Yeah.
get people up. Yeah. So about every 2 minutes, you're going to want to switch, or about every 5 cycles, you'll switch out. Okay. Or if you're using an AED, then when the AED shocks. Okay. AEDs. Every AED kit has a number of pins in them that are exactly the same. There'll be the AED itself, a set of pictured instructions on how to use it, at least 2 types of pads for every type of pad that's supposed to be in that kit, a pair of trauma shears, and a disposable razor. Okay. What are the trauma shears for? Yeah, as BLS providers, we need to expose the chest. If we haven't been able to do it, like we can't get through a bra or something, you take the shears right through down the middle. It works every time. Okay. Why do I need a disposable razor in an AED kit?
To shake that area where you put the
If they have an extremely hairy chest. Normal chest hair is not a problem. If you go, oh my God, Mr. Jones has a carpet full of hair on his chest, yes, you need to remove that. But normal chest hair is fine. If the pad's going to stick to skin, no problem. Okay? Most important thing to do with the AED is
turn it on.
turn it on. I'm not going to turn it on right now because I'm going to walk through where to apply the pad. I don't want to talk over it. Okay? Take your pads. There are 2 pads. Okay? Take one and place it to the right of the sternum. Use the collarbone as a reference line. Hang it vertically off the collarbone, basically in line with the nipple. The other pad goes on the mid-axillary line on the left side, a few inches below the armpit. Okay. Turn the AED on, follow the directions.
Apply pads to patient's bare chest.
Pads,
Plug in pads connector next to
connector.
flashing light.
flashing light,
Analyzing heart rhythm. Do not touch the patient.
clear,
Shock advised. Charging.
What am I going to do as soon as the AED says shock delivered?
Start CPR.
Yeah, we get
Now.
yeah.
Press the orange button now.
Clear.
Shock delivered.
1 and 2 and 3 and 4 and 5
Begin
and 6 and 7.
CPR.
Okay. As soon as that shock delivered, I am resuming compressions. Most AEDs have some type of built-in metronome. Okay, that'll help keep your compressions. Okay. The other thing is, if the person has a pacemaker, you will see the pacemaker typically on the right-hand side of the chest. You'll see a horizontal incision with a pacemaker beneath the skin. Okay, every once in a while they'll put them on the right-hand side. If you go on the right-hand side, make sure the pad is 1 inch away from that pacemaker. Okay. Who can remove the pads once they're attached?
How can we remove them?
Who can remove them?
Oh, who can remove them?
Advanced team.
Yeah, qualified medical personnel. Okay. Qualified medical personnel can, or the patient themselves. If the patient wants to remove them, what does that mean?
They're alive.
They're responsive, yeah. Encourage them to keep them on until the advanced team arrives or EMS arrives. Okay. They're going to be monitored every 2 minutes. Okay, every 2 minutes, the AED is going to cycle through and monitor again.
Analyze it, yeah.
Yep. Okay. Make sure you say clear and you visually inspect and make sure that everyone is clear. Okay. Especially when it goes to shock. And if someone is not clear when it shocks and they're accidentally touching the patient, you will then have 2 patients because you're going to shock them as well. Okay, it's real easy in the field to end up accidentally touching a patient. Accidentally kneel on their arms, or depending where their arms are, you can actually be touching them. Make sure everyone is clear. Okay?
Feeling okay?
I'm okay.
You don't look so good.
Just a little.
Well, what's wrong? Why are you holding your arm like
I
that?
need to go.
Bill? Bill! Can someone help us? What happened?
Ma'am, I'm a nurse practitioner. I can help. Sir, are you okay? Sir, are you okay? Carolyn, call a code. Joanne, can you get the AED?
I'll get the AED.
Bill? Bill!
Need a code team.
1,000, 3, 1,000, 4, 1,000, 5, 1,000, 6, 1,000, 7, 1,000, 8, 1,000, 9, 1,000, 10. No pulse, no breathing. 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10 and 11, 12 and 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
Adult pads. Don't touch patient.
Clear.
Analyzing. Shock advised. Don't touch patient. Press flashing shock button.
Clear.
Shock delivered. Start
1 and
CPR.
2 and 3 and 4 and 5 and 6 and 7 and 8 and 9
the code team
and
is on its
10
way.
and 11
Great.
and 12 and 13, 14, 15, 16, 17, 18.
Do you need me to take
19,
over
20,
for you next
21,
cycle?
22, 23, yes, 4, 25, 26, 27, 28, 29, 30.
One and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10 and 11 and 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 23, 24, 25, 26, 27, 28, 29, 30. 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10.
27, 28, 29, 30. I'll take over from here. Okay, what's the patient's status?
This is a 65-year-old male who was waiting in our waiting area. It was a witness cardiac arrest. We've delivered 2 shocks.
Okay. We're gonna do a couple scenarios. We're gonna try to go around the room. We'll rotate people in for each scenario. Everyone will have a chance to be a team leader. Okay. As a team leader, the team leader's responsibility is to manage the resources of the team and act as a coach as well. Okay. And after each scenario, we'll do a quick debrief. The team leader will tell me as a responding EMS what happened, and then we'll do a debrief of the scenario. Okay. In the debriefing part after the scenario is good. In real life, those happen all the time. What did we do right? What did we do wrong? What could we improve on? High-performing teams consistently do this, not only when they're practicing, or they also do it for real situations where they had a resuscitation situation. Okay, it continues to constantly help them improve and become better at what they do. Okay. As we say, this is a tangible skill. If you don't do it enough, you will lose it. That's why we recertify every 2 years. Okay. So you're going to be team leader first. Okay. You will get the AED. You will call 911 and get the BVM. Okay. I'm going to give you a scenario. You're going to do it there. Tell them what to do. They'll come back and help you when I tell them to. Okay. Team member, when you come back, make sure everyone's using, what type of communication do we use for situations?
Closed loop.
Closed loop communication, right? So go get the AD. I'll go get the AD. I'm back with the AD. Great, you're back with the AD. Apply it. I'll apply the AD. Make sure you're using closed loop communications. If you don't, that's how things get missed. Okay. If you know something, one of the team members isn't doing something correctly or not doing their job on the team, always tell the team leader. If you start picking up that job and then the team leader tells you to do something else, he might not know you're picking that up. They don't know, the team leader doesn't know that person is missing that. Make sure you notify the team leader of anything that's going on. Also remember, if you see signs of life, whoever sees the sign of life, say stop CPR as they're moving or whatever sign you saw, and convey that information to the team leader. Okay? Look, any questions? We'll use this one. All right. You said you work pediatric.
Psych.
Like, okay. So you have a juvenile psych patient came in. Mom comes in to check on them. You're having a conversation with the mother. Mother gets really pale, takes a deep breath, grabs her chest, or we'll say father, since these are all male mannequins. Dad gets pale, takes a deep breath, grabs his chest, and collapses right in front of you as you're in the waiting area. Go.
Okay? Sir, are you okay?
No response.
He's not breathing.
Not breathing, no pulse.
Go get the AED. What was the other one?
Call the code.
Call the code.
You're in a facility.
I'll call
You-
911 and
Get the BVM. Good job.
Breath. 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 Breath.
All right, you made it back. Come and help him.
I have
Bring a
really,
BVM. Bring a BVM.
oh, the baby.
Unplug it.
Apply pads to patient's bare chest. Plug in pads connector next to flashing light. Apply pads, plug in connector. Apply pads, plug in connector.
Don't kneel on his leg.
Apply pads, insert connector firmly. Analyzing heart rhythm.
What do you say?
Do not touch the patient. Shock advised.
clear.
Charging. Stay clear of patient.
On that cycle, call first switch.
Deliver shock now. Press the shock delivered.
Make sure you stay clear before you push that shock button.
Begin CPR.
Switch.
Remember, you're going to squeeze the bag first, then take over compression.
4, 5, 6, 7, 8, 9, 10.
And 12,
Okay, remember, every one of those beeps is a compression.
21,
Every one of the beeps is a compression.
40.
Listen to the beeps. Every beeps is a compression. His legs are moving.
Stop CPR. His legs are moving. He's breathing.
He's breathing his pulse. Yay!
He lives.
Then turn off the AED. Spread it. Bottom of the foot and shout again, hey, are you okay? As you're tapping the bottom of the foot. For a child, you'll still tap the shoulder. This brings up a great question. When is a child for BLS?
So from 1 year old to at puberty, it's puberty.
Until the onset of puberty. So 12 months or 1 year of age to the onset of puberty classifies as a child for BLS. Okay, an infant is 12 months and younger. Okay, for an infant, open the airway to a neutral position. Okay, and then simultaneously check for breathing, and you will check for the brachial pulse on an infant. Where's the brachial pulse? In the arm. Very good. For a child, open the airway to a slightly past neutral position using the head tilt chin lift. Then simultaneously check for breathing and a carotid pulse for no more than 10 seconds. Okay. Again, you're going to use the ABC Mimerick for rapid assessment. You're going to assess for life-threatening bleeding and your initial impression and check for a pulse and breathing simultaneously. Before initiating care for a minor, you must obtain consent from a parent or a guardian if they are present. If a parent or legal guardian is not present, consent is implied in life-threatening situations. Also, if you are alone and do not have a form of communication, you must decide to call or care first. Okay. Life-threatening injuries or illnesses in children and infants. Remember, care for a child or infant experiencing life-threatening injury or illness is similar to the same as caring for an adult. Okay. Respiratory arrest or failure. You are now presented with assessment findings for a pediatric patient in respiratory arrest or failure and be asked to determine appropriate care. Kathleen is an unresponsive 4-year-old child. She is not breathing and has a central pulse rate of 65. After obtaining consent and calling for additional resources, what would you do?
Get the ventilations.
Begin ventilations. How many and how often?
One every 2 to 3 seconds.
One every 2 to 3 seconds, yes. Deliver one ventilation in 2 to 3 seconds. Each ventilation should last about 1 second and make the chest begin to rise. You're gonna recheck the pulse and breathing after about every 2 minutes. So, if you were giving ventilations to a child or infant and you're giving one breath every 2 to 3 seconds, how many breaths would you give in 2 minutes?
60.
In 2 minutes? So just know, as you're counting the breaths, it's about 40, you need to reassess them. Okay? After 2 minutes of delivering ventilations to Kathleen, you stop to check her breathing and pulse. You notice that she is not breathing still, and her central pulse has decreased to 54 beats per minute with signs of poor perfusion despite adequate ventilation and oxygen. What are your appropriate actions to take? Immediately start CPR, yes. Start CPR, check every 2 minutes. If she's not breathing normally and has central pulse less than 60, you will begin compressions. Or if it goes above 60, you'll stop compressions when you're checking, okay? Cardiac arrest. You are presented with assessment findings for several pediatric patients in cardiac arrest. You will be asked to determine the appropriate care. Andres is a 6-month-old patient in cardiac arrest. You are the only provider present and must initiate CPR. What are the components of high-quality CPR for infants when performing single provider CPR?
2 thumbs.
Yeah, 2 thumbs, body position, standard kneel to the side of the patient at a slight angle so you can easily transition between compressions and ventilations. Hand positions. This is one of the big changes for people recertifying. Before, it was the alternative method. Now, the encompassing thumbs is the preferred method for delivering compressions to an infant, even as a single provider. 2 thumbs center on the lower half of the sternum, just below the nipple line. The alternative method is using the 2-finger technique if the required depth cannot be achieved with either the encompassing thumb technique or the 2-finger. You may consider using a 1-hand technique. Okay. Depth about 1.5 inches. Okay, for an infant. Rate is still 100 to 120 compressions per minute. Compression and recoil time should be approximately equal. As a single provider, your compression to ventilation ratio is 30 to 2. Again, avoid excess ventilation. You don't want to put too much air into an infant's lungs. For an infant, it does not take much air to fill their lungs. Okay. Again, minimize interruptions to less than 10 seconds. You're performing multiple provider CPR on Andres. How would you modify your technique?
Could do 15 to 2.
15 to 2, what else? Your positioning is going to be different. With multiple providers, you'll be positioned at their feet. Oops. Okay. Compression. One provider stands or kneels at the infant's feet and provides compressions using the encompassing thumbs. The other provider stands at the head or at the head of the patient and delivers ventilation using a BVM, and your compression ratio changes. It is now 15 to 2. You and another provider are performing CPR on Sadie, a 2.5-year-old child weighing 28 pounds. What are the components of high-quality CPR for children when performing multiple provider CPR?
Into 2.
15 to 2. Hand position with 1 or 2 hands, okay? With a small child, the alternative method is using 1-hand compressions. If they're smaller, you can achieve the appropriate depth, okay? Your depth will be about 2 inches. Your rate is still 100 to 120 per minute. Fully recoil, allow the chest to fully recoil. This should be about the same. And your compression to ventilation ratio for multiple provider for a child is 15 to 2. Again, avoid excess ventilations and minimize interruptions to under 10 seconds. You're performing single provider CPR on Sadie. How would you modify the compression to ventilation ratio? 32. Yep. True or false, to perform high quality chest compressions on Sadie, you need to use the 1-hand technique. True. True. For smaller children such as Sadie, you would use the 1-hand technique, yeah.
1 hand meaning fingers?
1 hand.
Oh, like,
1 hand.
Oh, okay.
1 hand. Just like you would when you're doing CPR 2-handed, but just 1 hand.
Gotcha.
She's 2.5 years old and weighs 28 pounds. You don't need a lot of force. Okay. There are key points. Deliver 2 ventilation before performing CPR when they were in a drowning situation. Okay. You also consider delivering 2 ventilations before starting CPR in a child or infant with cardiac arrest from a pulmonary respiratory etiology. Okay, so if you suspect it's respiratory, you can also deliver 2 ventilations. Okay, if you think respiratory is the reason that they went into cardiac arrest. Opioid overdose, in addition to basic life support, children gives you the code card for opioid. Okay, opioid overdose. Care for children, infants is similar to adults with 2 notes. 1, your respiratory arrest and failure rate delivery is different. It's 1 ventilation to every 2 to 3 seconds. For children, infants in cardiac arrest, start CPR immediately and use an AED when it's available, and follow the manufacturer's or facility protocols for administration of naloxone. Okay. If they have an advanced airway, for children or infants have advanced airways, if an advanced airway is in place during respiratory arrest or failure or cardiac arrest, deliver 1 ventilation every 2 to 3 seconds. And the second provider performs compressions at a rate of 100 to 120 per minute. They're going to give continuous compressions if there's an advanced airway. High quality CPR for children and infants. Okay. We don't have any children mannequin. It's very similar to doing an adult. If you had a child, when you did the online videos, they said you could do a 1-hand technique. This is the 1-hand technique. Okay. Again, you want to compress to about 2 inches and allow the chest to fully recoil. Okay, that's the 1-hand technique. Okay, for children. Single provider CPR for infants.
When you're the only provider initiating CPR for an infant, first, make sure the crib is at an appropriate working height or use a step stool. Lower the crib side rail closest to you, place them on a firm, flat surface, and obtain a CPR board like we have here. Or you can use a CPR-ready crib or bed. If you're not at the infant's bedside, use a stable surface above the ground, such as a table or a countertop, because it's usually easier to perform compressions from a standing position rather than kneeling at the infant's side. To perform chest compressions, use the encircling thumbs technique. Place both thumbs side by side on the center of the infant's chest, just below the nipple line. Then use the other fingers to encircle the infant's chest toward the back, providing support. Using both thumbs at the same time, press down on the infant's chest about 1.5 inches deep at a rate of at least 100, but no more than 120 compressions per minute, like this. As you do this, allow for complete chest recoil. Alternatively, you can use the 2-finger technique to perform chest compressions. Place 2 fingers of your hand closest to the infant's feet in the center of the exposed chest just below the nipple line on the sternum. You can use your index and middle fingers or your middle and 4th fingers to provide compressions. Fingers that are more similar in length tend to make compressions easier to deliver. Press down on the infant's chest about 1.5 inches deep at a rate of at least 100, but no more than 120 compressions per minute, like this. As you do this, allow for complete chest recoil. To provide ventilations, place an infant resuscitation mask over the infant's nose and mouth. Then place your fingers on the bony part of the chin and open the airway to a neutral position. Avoid hyperextension or flexion of the neck. After making a good seal, provide 2 ventilations. Each one should last about 1 second, making the chest begin to rise. Okay, so let's take a look at 1 cycle of CPR. Keep in mind, the ratio of compressions to ventilations is the same for an adult or child. That is 30 compressions to 2 ventilations. 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10 and 11 and 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
Okay. With an infant, you're going to use the encompassing thumbs technique. Okay. Alternatively, you consider using the 2-finger technique. Okay. Or if you can't achieve proper depth, then you can do the 1-handed technique. The key when you're doing single provider is you are at an angle to the infant. The infant's at an angle to you. The way it's easy to reach down and give the compression and alternate between. You know, you go to multiple provider, you're at their feet. Single providers off to the side, multiple providers at their feet. Okay. Okay. We're going to do a set of compressions using the encompassing thumb for approximately 1 minute. Okay. Go ahead, you'll assess the scene, you'll check for responsiveness. How do we check for responsiveness on an infant?
Tap the feet.
Tap their foot and ask, baby, are you okay? And tell someone to call and get help, and then you'll do 1 minute of compressions on the infant. Okay? All right, go ahead and get ready.
Hey, are you okay? Are you okay?
Are you okay? Baby, are you okay?
You're tapping the bottom of the foot. That's the leg. The bottom of the foot. The bottom of the foot. There you go.
Are you okay?
And 1 minute of compressions. You're still trying to give 100 to 120 per minute. It's still 2 compressions per second. You're not stopping, you're just giving 100 to 120 compressions for the entire 1 minute. You're doing straight compressions. You're not giving rescue breaths at this point. You are not giving rescue breaths at this point. You're giving straight compressions for 1 minute. Stop. Okay. Any questions about single provider or the encompassing thumb technique for infants? Multiple provider CPR for infants.
When multiple providers are performing infant CPR, their positioning and chest compression method differ from those used for an adult or child. Francis, Jeff, and I will show you these differences. I'm going to provide chest compression, so I need to be at the infant's feet.
Since I'm going to be providing ventilations, I'll stand at the infant's side, and Jeff will stand at the infant's head to maintain the airway.
With multiple providers, compressions are delivered using the encircling thumbs technique. For this technique, place both thumbs side by side on the center of the infant's chest just below the nipple line. Then, use the other fingers to encircle the infant's chest toward the back, providing support. Using both thumbs at the same time, compress the chest about 1.5 inches at a rate of at least 100, but no more than 120 compressions per minute. Let the chest return to its normal position after each compression.
Jeff will seal the mask while using the EC technique, while opening the airway using 2 hands. The BVM should be appropriately sized for the infant to ensure an adequate seal.
Since we have multiple providers caring for an infant, we need to change the compression to ventilation ratio to 15 to 2. That is 15 compressions to 2 ventilations. You guys ready?
Ready.
1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10 and 11 and 12, 13, 14, 15. 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10 and 11 and 12, 13, 14, 15.
Switch positions about every 2 minutes. The compressor calls for a position change by saying switch in place of the number 1 in the compression cycle.
14, 15. Switch and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10 and 11 and 12, 13, 14, 15.
1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10 and 11 and 12, 13, 14, 15.
As with any patient in cardiac arrest, if an infant shows an obvious sign of life, stop CPR and monitor the airway, breathing, and pulse.
1 and 2 and 3 and 4 and 5.
All right, you're going to perform 2 cycles of CPR and then smoothly switch roles. Focus on minimizing interruptions in chest compressions for less 10 seconds. The compressor will call for a roles change by saying switch in the place of number 1 at the beginning of the second compression cycle. Okay. Go ahead and just partner up in 2 people. Each of you do 2 sets of compressions. That person will use the BVM and then call for a switch. Okay. There you go. Start from the beginning. You're going to assess the scene, check for responsiveness, whole 9 yards.
You okay? Are you okay, baby? Are you okay?
No response.
No breath, no pulse.
Over your multiple provider. There you go. Yep. Remember the mask. When you enter the mask, goes towards the nose. When you enter the mask, goes towards the nose.
They're really the ones that said that it was.
6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
4, 5, 6,
Till I'm back to neutral, remember.
10, 11,
1, 2, 3,
13,
4, 5, 6, 7,
Call for a switch.
8, 9, 10, 11, 12,
Switch.
13,
2,
14,
3, 4, 5, 6, 7, 8, 9.
Call for a switch.
Switch. 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
That's doing a breath tube at the head of the patient.
2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
Call for a switch or the next cycle.
Switch. 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
All right, good job. AED used for children and infants. Okay. Infant children 8 years or younger or weighing less than 55 pounds, you can use pediatric pads if they're available. Okay. Here's a set of pediatric pads. This is what they look like. They're a lot smaller. Okay. How do you apply pediatric pads to a pediatric?
Front, choose back.
Yeah, the front and on the back, right? Anterior, posterior, center of the chest. Okay. Children older than 8 years old or weighing more than 55 pounds, you use adult or children pads on. Okay. Infants always use the anterior posterior pad placement. Children use the anterior lateral pad placement or anterior posterior pad placement, and the pads risk touching each other, or the AED model uses this type of pad placement. All right. And then follow guides for checking rhythm as we indicated for adults, right? Every 2 minutes, we're going to reassess for pulse and breathing. Okay.
Do you have a 2? You might. Let's see. Do you have a 2 or a pink? Oh, awesome. What's on there? Snail, right? Theo? Theo? Hey, buddy, all right? Oh, no. Theo! Theo! Joe, get the AED and get help.
I grab the AED and get help.
1, 1,000. 2, 1,000. 3, 1,000. 4, 1,000. 5, 1,000. 6, 1,000. 7, 1,000. 8, 1,000. 9, 1,000. 10.
No breathing, no pulse.
Code blue, pediatric playroom. Code blue, pediatric playroom.
1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10 and 11 and 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10 and 11
I got the
and 12,
BVM.
13, 14, 15, 16, 17, 18, 19,
Pediatric
20,
pads.
21, 22,
Attach
23,
defib pads to patient's bare
24,
chest.
25, 26, 27, 28, and roll. 29, 30. I'll take over once it analyzes. 1
Start
and 2
CPR.
and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10 and 11, 12, 13, 14, 15. 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10 and 11 and 12, 13, 14, 15.
Amy, we'll take over CPR. Can you tell me what happened?
Yeah, we were just sitting there playing and he slumped and fell over. I tapped him and called his name. He didn't respond, so I checked his pulse and breathing, and he had neither.
1,000, 2, 1,000, 3, 1,000, 4, 1,000. No breath and no pulse.
Okay.
Go get an AED and call 911.
Don't bring the AED.
2, 3, 4, 5, 6, 7, 8, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. 2, 3, 4, 5, 6, 7, 8, 9, 30. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 22, 23, 24, 25, 26, 27, 28, 29, 30.
All right, team members, come back and help her out.
Start the BVM.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14.
Apply pads to patient's bare chest. Plug in pads connector next to flashing light.
1, 2, 3,
Analyzing
4,
heart
5.
rhythm. Do not touch the patient. Shock advised. Charging. Stay clear of patient. Deliver shock now. Press the shock delivered.
1, 2, 3, 4,
Begin
5,
CPR.
6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
Call for a switch.
Switch 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
All right, EMS has arrived, relieved you, and the team leader, what happened?
Baby was at the pharmacy, was collapsed, became unresponsive, checked, no breath, no pulse, started CPR, 2 cycles, and 1 shock delivered.
Okay. Team members, how do you think team leader did? Team leader, how do you think team members did?
They did very well.
A couple quick things, when you're doing single provider, you're at an angle, you were right at their feet. So there's no way, when you switch, you're supposed to be at their feet. So when you're by yourself, you're at an angle by their side. So it's easier to lean down and give the rescue breaths. So when you go to multiple, you're at their feet. Okay?
To make way for the other.
Yeah, make way for the other one, yep. All right, we're gonna switch, you'll get the
To care for a responsive adult who is choking, first call for additional resources and obtain the patient's consent. Are you choking? Can you speak? Call for the rapid response team. My name is Chris, I'm a nurse. May I help you? To provide back blows, position yourself to the side and slightly behind the patient. Provide support by placing one arm diagonally across the patient's chest. Then bend the patient forward at the waist so that the upper body is parallel to the ground or as close as it can be. Using the heel of your other hand, give 5 firm back blows between the patient's scapula. Make each blow a separate and distinct attempt to dislodge the object, like this. First, stand behind the patient with one foot in front of the other for balance and stability. If possible, place your front foot in between the patient's feet like this. Then get your hands in place. Using 1 or 2 fingers to find the patient's navel, make a fist with your other hand and place the thumb side of your fist against the middle of the abdomen just above the navel. Grab your fist with your other hand. Now give quick inward and upward thrusts. Be sure to make each thrust a distinct attempt to dislodge the object. Here's what it would look like. To perform chest thrusts, position yourself behind the patient as you would for abdominal thrusts. If the patient is in a wheelchair like Will here, you may need to kneel. Place the thumb side of your fist against the center of the patient's chest on the lower half of the sternum. Then cover your fist with your other hand and pull straight back, providing a quick inward thrust into the patient's chest. If you are in a healthcare facility and back blows, abdominal thrusts, or chest thrusts are not effective or practical, use a combination of basic or advanced airway management techniques based on your level of training and experience.
The technique for clearing an obstructed airway of a child is similar to that of an adult, with slight modifications. As always, when caring for a child, be sure to obtain consent from a parent or guardian before providing care. Of course, if they are not available, consent is implied. Jane is going to help me demonstrate this skill. You might want to kneel behind the child to provide effective back blows, abdominal thrusts, and/or chest thrusts. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5.
All right. You're working team to 2. The first person will perform 5 simulated back blows and 5 simulated abdominal thrusts, then you'll switch. Okay. Keys, when you're doing the back blows, make sure you're perpendicular to them or slightly behind them. Reach underneath their arm and then bend them forward. Okay, and 5 back blows. When you do the abdominal thrust, make sure your leg is in between theirs. And then it's an inward, it's an in and up, it's a J motion, in and up, okay? The other key is if the person is significantly taller than you and you're doing the back blows, have them kneel down so you equalize the height, that way you have better control of them. And if they do happen to fall and they're closer to the ground, they're not falling as far. All right, give your partner, each of you do 5, simulate the back blows and simulate the abdominal thrust, okay? The back blows aren't as bad as the abdominal thrust, but if you do the abdominal thrust, really, you can hurt them and you might actually cause something to come up. So the back blows, you're perpendicular to them.
Unchoke you.
You're perpendicular, yep, reach underneath their arm, grab their shoulder, and have them bend forward.
4, 5.
1, 2, 3,
1,
Yep.
2, 3, 4.
Vicky, make sure your leg is in between there, that way if they become unresponsive, you can support them, they don't.
1, 2, 3, 4, 5.
Again, make sure your leg is in between theirs. That way, you have a good stance. If she becomes unresponsive, you can catch her and support her on your leg. No, your leg is only if you're doing.
When I do that.
When you do the abdominal, okay. Yeah. Then you can switch. After you've done the 5, go ahead and switch.
Okay.
Yeah, I'm.
When you do a back blow, you're perpendicular. Move to the side.
Oh, to the side.
Yeah, to the side, yeah.
Yeah, that's much better.
Remember the back blows come first, then the abdominal. All right, good job.
Yeah.
Obstructed airway for a responsive infant.
When a responsive infant is choking, clear the airway with a series of 5 back blows and 5 chest thrusts. But first, obtain consent from the parent or legal guardian if they're present. Of course, if they're not, consent is implied. Place your forearm along the infant's back, cradling the back of the infant's head with your hand. Place your other forearm along the infant's front, supporting the infant's jaw with your thumb and fingers. Hold the infant in a face-down position along your forearm, using your thigh for support and keeping the infant's head lower than the body. Use the heel of your hand to deliver back blows between the infant's scapula, keeping your fingers up to avoid hitting the infant's head or neck. Provide 5 firm back blows with each one separate from the others, like this. 1, 2, 3, 4, 5. If back blows don't dislodge the object, try chest thrusts. Position the infant between your forearms, support the head and neck, and turn the infant face up. Then lower the infant onto your thigh with their head lower than their chest. Now, place 2 fingers in the center of the infant's chest, just below the nipple line. Then give 5 quick chest thrusts about 1.5 inches deep. Let the chest return to normal position, keeping your fingers in contact with the breastbone. Each chest thrust should be separate from the others. 1, 2, 3, 4, 5. Continue to provide sets of 5 back blows and 5 chest thrusts until the object is forced out and the infant can cough, cry, or breathe, or the infant becomes unresponsive. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5.
Okay. When you do this, you want to support their head. Okay. Now I'm in a downward angle. Okay. What you do is make sure their leg is underneath yours. You can hold it. Because if they're responsive, what are they going to be doing? Wiggling around, right? So if they actually wiggle free, you still have hold of their leg. Okay. When you're sitting down, go ahead and sit down with them. And use your leg as extra support. Okay. Have your leg out. Extend it out. That way you can keep it at a downward angle. 1, 2, 3, 4, 5. Support the head. Flip them over the other arm. Then 5 chest thrust. Okay. Go ahead and do 2 cycles of each. 5 back blows, 5 chest thrusts, 5 back blows, 5 chest thrusts with your infant. Remember, keep them at a downward angle. You want the shoulders below the hips. Put your leg up, keep your leg up. Yeah, there you go. You're gonna keep that downward angle. Just 2 fingers. Remember, have them straddling your whole arm. Have them straddling your whole arm. There you go. Downward angle. You want the shoulders below their hips. Until they become unresponsive or they're crying and coughing. Okay. Obstructed airway for unresponsive adults, children, and infants. Bring a 21-year-old patient with an obstructed airway. You've been attempting to clear her airway when she becomes unresponsive. What action should you take? Ensure that she is on a firm, flat surface and immediately begin CPR. When they become unresponsive due to choking, immediately place them in a CPR position on a hard, flat surface. Begin compressions. After each set of compressions and before ventilation, open the patient's mouth and look for the object. If you can see the object, remove it using a finger sweep. Do not perform any blind finger sweep. If you don't see anything, don't go sweeping in there. Attempt 2 ventilations. Never try more than 2 ventilations during 1 cycle of CPR, even if the chest does not rise. Continue performing cycles of compressions and ventilations, checking for an object before each set of ventilations. Check breathing and pulse every 2 minutes. If a pulse becomes absent, start CPR immediately and use an AED when it's available. When caring for Georgette, a 7-month-old patient, she becomes unresponsive. You have initiated CPR. You must now look in her mouth for the object that is obstructing the airway. If seen, how should you remove the object?
Finger sweep.
Finger sweep, yep. After each set of compressions, look in Georgette's mouth for the object. If you can see it, remove it quickly using a pinky sweep. You're going to use your pinky. You're not going to use your index finger on an infant. It's going to be too big. You're going to use your pinky. Okay? Any questions?